Well, all right, ladies and gentlemen, it's time to look at our second set of medications on the list, which is going to be the group that falls under nervous system part 1. The medications we're going to look at in this lecture are going to be those that are barbiturates, opiates, and other drugs that affect the primary central nervous system. So I figure by this point in the program, you're probably beginning to become a little stressed and you're probably getting a little anxious. But just calm down, take a breath, get your drug cards out or your blank note cards, and let's talk about the next set of medications for you, all right? All right, the first drug we're going to look at is going to be the drug morphine. And so here on our slide, we see morphine. And we have a lot of different trade names that morphine can fall under. Morphine can be called Astromorph. You may see it as Roxanol. In Europe, they sell this as Infomorph. So there's a few different trade names. And to be honest with you, if you know Astromorph or any of the morphs, you probably will be okay. What we want to talk about is what classification this is. And this is going to be the first drug class, or the first drug that falls into the class opiate analgesics, which we will discuss. Now, opiate analgesics are also known as opiate agonist. It is an agonist because it stimulates an opiate receptor. So, as our class, it is an analgesic. If you remember, an analgesic is any drug that helps decrease the pain sensation or the pain response that the brain gets. And an agonist is any drug that stimulates or activates a receptor inside the body. So that's why we're going to put morphine in this classification. When you're talking about narcotics, and more importantly, when you're talking about opiates, one thing to understand is that narcotic analgesics affect the central nervous system by decreasing a lot of the normal central nervous system activity. Basically, what we think of when we think about the mechanism of action of your opiates, which includes morphine, is that morphine and many of the other narcotic analgesic drugs act by mimicking the effect of narcotic substances that are produced naturally inside the body. These are what we call indigenous opiates. These are basically what we know of in the body as the endorphins. They're present in the brain and in the spinal cord, and what these endorphins do is they bind to specific opioid receptors located throughout the brain. If you've read your lecture material, then you know that there are several types of opioid receptors. There are receptors which are called the mu receptors, and these are the ones that reduce awareness and perception of pain. The kappa receptors do close to the same thing, and then you have the sigma receptors that are located in the brain. We know that the mu receptors actually mediate morphine-like analgesia. Your kappa receptors mediate what we call pentosine-like analgesics, and sigma receptors mediate the dysphoria, the hallucinations, and the respiratory and vasomotor stimulation. And so mu is the receptor, the opiate receptor that primarily deals with pain sensation, which is the one we want to aim at. And so basically what morphine does, along with many of the other opiates, is it binds to the opiate receptors, and therefore it stimulates the blockage of many of those pain receptors, and it allows the mu receptors to be activated, which help manage pain receptors. Some of the things that these opioid receptors also will do is they have the potential of inducing hypotension and depression of the vasomotor center in the brain, and they release neurohistamines. These neurohistamines, of course, play a large part in vasodilation and capillary permeability. We know that opiates also reduce the stimulation of the sympathetic nervous system, which therefore decreases pain and decreases anxiety. Some of the things that we would expect this drug to do, of course, is we'd expect it to help reduce the heart rate, reduce the myocardial oxygen demand, and the workload of the heart. Well, who gets morphine? Well, the patients that we're primarily going to give this to are going to be patients who are in acute pain. We also give it to patients with chest pain, even though that's kind of being taken away from the protocols. We still give it for chest pain. We give it to patients who have a severe congestive heart failure because it decreases the oxygen demand on the heart. And we also, of course, give it with any patient who has got pulmonary edema associated with that. Now, what's the dose of morphine? Well, you have a wide range for adults. We can give this medication IM. We can give this medication sub-Q. We can give this medication IV, of course, which is one that we typically use. We administer it very slowly over several minutes, and the dose is anywhere between 2.5 milligrams, and we can go all the way up to 15 milligrams of this medication, even though that's kind of a high dose of it. You could technically go all the way up to 15. Usually it comes applied in 10 milliliter vials, or you may even can get it in all the way up to 50 milligrams per milliliter vial. So you got to be real careful about which concentration you're using. Contraindications. We do not give morphine for patients who have head injuries. We do not give this for patients who have significant respiratory depression due to COPD or some type of decreased respiratory drive. We do not give it to patients who are hypotensive or who are in shock. We also try to avoid giving this drug to anyone who may have had any MAOIs within the last 14 days. Notice here that asthma is included on this screen because asthma, morphine will cause bronchial inflammation because of the histamine release. And that can, of course, cause an asthma exacerbation. Morphine has a pregnancy class of C. We always want to dilute this drug down. I would encourage you to dilute it down with at least 5 milliliters of saline. Most of the time we'll dilute it all the way down to 10 milliliters. The only other precaution to keep in mind is that this medication is a class or a category 2, class 2 narcotic, and so that means it's very highly addictive. So you got to be real careful about that. If you push it too fast, or if you give a patient too much, of course, you can cause respiratory depression. You can cause them to have a vasomotor response and have a blood pressure drop. The antidote for an opiate overdose is going to be naloxone, which is also known as Narcan, which we'll deal with a little bit later. The next drug to mention is hydromorphone. Hydromorphone is known as Dilaudid, or Dilaudid. And this is also a Schedule II drug, which means it has a high potential for abuse. This medication works very similar to morphine. It is a semi-synthetic mu-opioid agonist, which means this is a drug that's being made that is partially a synthetic version, and it also responds and acts like a natural mu agonist. And so it is a semi-synthetic mu-opioid agonist. It is what it literally is. It is a hydrogenated ketone of morphine. So hydromorphone is the left hand versus the right hand of the chemical morphine. And so it is a hydrogenated ketone of morphine. It has the same chemical components, but they're arranged a little bit differently. It is more powerful than morphine, so you have to be very careful with it. It is used, and it's of course used as an analgesic. It's used for sedation. It binds to the mu-opioid receptors, and it has a very high affinity to those receptors, so it stimulates a lot of the depression. We usually use this drug only for moderate or severe pain, and typically this is going to be a drug that will not be administered on the ambulance because of the high abuse potential. This will be a drug you see used a lot in the hospital and the ER. The dose of it is anywhere between 0.5 to 2 milligrams. It can be given IV, IO, IM, sub-Q, PO. There's a lot of ways to take hydromorphone. And we draw it up and occasionally give it at the hospital for kidney stones quite a bit. Special considerations, of course, significant respiratory depression can occur, so you've got to be very careful with that because of its high potential and because of its high affinity to the opiate receptors. Its antidote is also going to be Narcan. In case there's an accidental overdose on it, then you would still want to use Narcan just like you used in your morphine overdose. Don't really know the pregnancy category for this drug. It's quite hard to find anywhere that tells it to you, but we're going to make an assumption that it is a category C, very similar to morphine. So that is hydromorphone. And basically what I'd want you to know about this medication is that it is a hydrogenated ketone. Now, what happens is you'd actually take hydromorphone, and they use hydromorphone quite a bit in many of your antitussives. If you remember, antitussives is the classification that deals with coughing. And they use a version of hydromorphone. They basically take a chemical component of it to make dexamethasone, which is what you use a lot in your over-the-counter and your prescription anti-cough medicines. And so hydromorphone can be broken down into a lot of other individual components. It is quite more expensive than morphine, and so you don't see it used and abused as much on the street as you do morphine, but you can take morphine and actually hydrogenate it into hydromorphone, which is very abusive. So the next drug on our list is fentanyl. Now, if you ask me, this is the drug that really is taking over pain management in EMS. For years and years and years, morphine was kind of the key drug. It was very cheap, it was very user-friendly, and it was kind of the hallmark opiate. In fact, it is the prototype opiate agonist. And if you remember from lecture or looking in your book, what it means when it talks about a prototype is it is the basic chemical structure. It is the one that is kind of the hallmark. It has all the characteristics of that classification. Well, morphine is actually the prototype for the opiate agonist, but things have begun to change the last 5 to 10 years, and this medication here, fentanyl, has really begun to take over the pre-hospital setting. And the reason is because what this drug does, and more importantly, what it leaves out compared to morphine. So let's take a look at it. Fentanyl citrate is also known as sublimase, and it is a narcotic analgesic, which means another class of it, obviously, is it is a opiate agonist. It stimulates the opiate receptors. And what this one does is it primarily interacts with the mu receptors, but it also has a little bit of the ability to bind to the kappa and the delta receptors. Now, if you remember going back, we talked about the kappa receptors. The kappa receptors are the ones that deal with the pentazine, analgesic, and sedation. And the delta receptors also deal with pain sensation. So here you have this really great drug that gives you the mu receptor stimulation, also gives you the kappa and the delta receptor. So basically it is binding almost completely to these opiate receptors. But one thing that fentanyl does not do is it does not cause the histamine release that morphine does. And therefore you do not get the vasodilation. You do not get the capillary permeability issues. And so that's a great thing. And so what it does, it increases the patient's tolerance of pain and decreases the perception of suffering. The pain still exists, it's just the patient may not be able to actually recognize the pain. It also, because of its analgesia effects, alters the mood, makes the patients have a feeling of euphoria and dysphoria. It depresses the respiratory center, but not as significant as morphine does. It also helps with the cough reflex. Of course, with all of your opiates, you're going to get decreased constricted pupils. And so you give this drug very similar. It is given for severe pain. It's very similar to morphine. It's much more potent. It also does not last as long. and it doesn't have the emetic response, so they don't feel like they need to vomit as much, and it doesn't cause the vasodilatory effects. We do not use this drug a lot for chest pain protocols because it doesn't have the vasodilatory effects. Therefore, it's not doing what morphine does for chest pain. And so this drug is really great for musculoskeletal injuries. It's great for broken bones. It is a good pain medicine. The dose of it is 50 to 100 micrograms. And we give this in 25 mic increments. So you would either give them 25 to start with, or if your protocol allowed you to, you could give them 50 to start with, and then you go up by 25s. A good policy would be to start with 25 mics and then go up in increments of 25. Notice here your PEDS dose is 1 to 2 mics per key. We avoid giving it to patients who have had MAO inhibitors, who have myasthenia gravis. We don't give it to patients who have head injuries, and so because of the potential there to cause a more significant decrease in the respiratory center. There's a couple of drugs that it does not work well with. If the patient is taking pentobarbital or they're taking thiopental for any type of their seizures, we try to avoid that. It reacts poorly with that. If they're drinking alcohol or they've taken some other type of CNS depressant, then it can potentiate this, which can make it very significantly potentially dangerous for their blood pressure. And as I've said, MAO inhibitors can cause these patients to have a hypertensive response. It is a pregnancy category B, which means it looks really good for your pregnant women. It's really good for that. Notice here that they have it both in nasal sprays. They have it in, this is your buccal administration where you put it on their cheek. And they make the lollipops for kids, which is very common when you have these kids going in to have some type of procedure done, such as eyes or some type of setting of a bone. They'll give these kids lollipops, which I wish I had some of those at home some days. So I might actually have some in my office if it'd be nice. Treatment for it, for an overdose, is going to be the exact same as morphine and hydromorphone. You would give them Narcan, which is naloxone. And so this is a really good drug, a really good medication. And personally, I kind of think that this is going to be the medication that takes over pre-hospital pain management. We're going to talk about another drug, a barbiturate in a little bit, or a benzodiazepine in a few minutes, called Versed. And most of your companies are switching to a fentanyl and Versed combination, and that's even a good dose for medicated assisted intubation. At one of the services I work for, we give 50 of fentanyl and 4 of Versed, and that almost puts a patient down enough for me to be able to intubate them and control their airway when we need to. So, a little bit of combination with a barbiturate or with a benzodiazepine really makes a difference with this drug. And morphine, on the other hand, potentiates all that stuff, makes it so much more dangerous to their vascular status. And so I think fentanyl is probably going to become the way to go when you have Versed along with it. So, all right, well, let's look at the next one. All right, the next drug, or the next opiate to mention, is Mepridine. And Mepridine here, as you can see, goes by the trade name of Demerol. It is a synthetic opiate agonist. It is also a opiate analgesic. Very similar to the other opiates we've used, except Demerol is a 100% synthetic opiate. It is designed in a laboratory to bind to opiate receptors. But Demerol has a couple of unique features. It is primarily a kappa opiate receptor agonist, which means unlike morphine and unlike fentanyl, which has a lot of mu receptor stimulation, this one is primarily a kappa receptor. Now, that does take away a lot from this drug. On the bright side, this drug does not have the vasodilation. It doesn't cause the significant drop in pressure most of the time. Demerol also does not typically cause respiratory depression. But because it does not have the mu receptor ability or the sigma receptability, this drug does not do real well as far as sedation. It doesn't do real well as far as euphoria. It is not a universally great pain medicine. Now, where it does work very well is is because of its kappa-related receptors. There are a lot of kappa receptors located in the musculoskeletal system. A lot of your nerve endings that go to your muscles and your bones and your joints and those regions of your body have a significant amount of kappa receptors available. And so what this medication is used primarily for in EMS, it is used for musculoskeletal type injuries. You have a patient who has broken a bone, they have fractured their leg, or they've twisted and broke their ankle, and you're not wanting to sedate them or give them a large amount of pain medicine like morphine or fentanyl. Say they're allergic to one of those drugs, or just say that it's not necessary. You need to do some localized pain relief. Demerol works pretty well with musculoskeletal injuries, pulled muscles and things like that. But it's kind of going away in EMS. We do give it for moderate to severe pain. It produces less smooth muscle spasms. It does not produce as much constipation. It doesn't cause as much depression of the respiratory center than the morphine does. The onset is a little bit more rapid than morphine, which is really good for your musculoskeletal injuries, and it's a little bit shorter. And so this is a really great drug to give for a patient who's broken an arm, and you just need to get them to the hospital and let them be able to x-ray it and see what needs to happen. And you don't want to give them a lot of a strong-powered opiate that they may have to come out of before they go to surgery. And so Demerol is good for that. But it's some of the side effects of the Demerol that's made it fall away. The dose of Demerol is 50 to 100 milligrams. That's supposed to be milligrams, not mg. We give this IV. You can give it IO. You can also give Demerol IM, which is done a lot for patients who can't have IV access. We try to keep it away from patients who are taking MAO inhibitors. We do not give it for labor pain because of some potential problems that it has there with the smooth muscles of the uterus. We don't give it for patients that have head injuries or they have unknown abdominal pain. Here are some of the problems with it. It causes extreme nausea, and you have to be very careful about giving it to patients who have asthma or COPD because it stimulates receptors that actually will cause a asthma attack or exacerbation of the COPD. We don't give it to patients who have seizure disorders because Demerol may cause the seizure disorder to reappear. And if we have a patient who has already got a central nervous system depression and altered LOC, we try to be careful with it. It causes nausea. Typically when we give Demerol, we have to turn around and give it with an antiemetic or an antihistamine such as Phenergan or Zofran or Compazine. And so anytime you go to give Demerol, just go on and plan, you're going to need to give something for nausea, which is pretty common. It has a C/D pregnancy category, which means, to be honest with you, if you have a patient in pregnancy, you probably want to do your best to stay away from Demerol unless you have to. The antidote for it, like all the other opiates, is going to be Narcan. And I think you're going to see this stay on the trucks for a little while. In fact, a lot of trucks have still got it. But Demerol is something that's kind of going away. I wouldn't be surprised that Mepridine kind of fades into the black box category before long. And so, but since you still do have it on the trucks, we still have it at MServ, and many of our services in the area still contain this drug, then you use it for musculoskeletal trauma when it's isolated. You know, if I have a kid who falls and breaks his leg, or I have a man that steps off a bus and I don't have fentanyl, then Demerol would be the next choice probably. And so it's just one of our other opiate type receptors. But remember, it's primarily a kappa, and that's going to be on your test. It's primarily a kappa receptor. All right, let's turn our attention towards some non-opiate based drugs. The first non-opiate that we're going to look at today is going to be acetaminophen. And, the trade names for acetaminophen are quite long. You have everything from Tylenol to, as you notice here, the Feverol, Ganapad, Panadol. When you go outside of the United States, there's a lot of different names that appear for acetaminophen. Datril, Panadol, and Tylenol are probably the three most common we'll deal with. Its classification, it is an NSAID. It is a non-steroidal anti-inflammatory drug. But if I wanted you to make sure you understand the major classes, not only is it an NSAID, it is a COX inhibitor, which is a cyclooxygenase inhibitor. So under ibuprofen or under acetaminophen, you notice here, I don't know if you noticed that I have the wrong bottle up on the picture here. I have ibuprofen up on the picture where it needs to be acetaminophen. So, but if your main classification is going to be an NSAID, a COX inhibitor, and it also is a analgesic and an antipyretic. Antipyretic, of course, being the anti-fever part of the drug. You know, acetaminophen is really an unknown drug even to us today. We really are not sure the mechanism that this medication does, but we suspect that it inhibits the cyclooxygenase in the body. And, you know, a lot of recent research has suggested that it is highly selective to the COX-2 receptors. Now, we'll talk a little bit in class about what the cyclooxygenase inhibitors do. But as a general rule, basically these are working as medications to stop some of the inflammation, or more importantly, stop some of the pain receptor enzymes that get released during some type of fever or cell damage. It has many times been thought that this would be a good substitute for aspirin, but unfortunately that's not entirely correct. Acetaminophen does produce adequate analgesic effects, and it also produces adequate antiparesis, but there is no study that has proven that its anti-inflammatory activity is significant. And so it does reduce elevated body temperature by working on the hypothalamus, and it does effectively manage pain by inhibiting prostaglandins and other type COX enzymes. And so I would give it for mild pain, we give it for inflammation, and we can give it for fever. The dose has quite a large range. Our dose for adults typically we say is anywhere between 500 to 1,000 milligrams. So anywhere between 500 milligrams to a gram PO. Your children, it's much more specific though, and one of probably the most standard dosing is to do it 15 milligrams per key. We don't want to let patients take acetaminophen if they have alcoholism or have some type of chronic liver disease, because this is a medication that is very toxic to the liver. In fact, a lot of times you'll see kids that overdose on acetaminophen. They take a whole bottle of Tylenol. Well, unfortunately, if you take Tylenol too much and if you overdose on Tylenol, that potentially destroys a large section of the liver. And so the only antidote for it, and this is the other problem, you either have to have a gastric lavage and pump the stomach, or if you respond to a house in which there's a kid who has taken 2 whole bottles of adult ibuprofen and you still have activated charcoal on your truck, if you can administer the activated charcoal within 30 minutes of the ingestion, then you can help bind some of this. The problem is if you take an overdose on ibuprofen, on acetaminophen, and you overdose on Tylenol, and you wait several hours before you seek medical care, the problem is there's not a lot that can be done for you. You're going to suffer liver damage. You're not going to die acutely. You're not going to probably die in the next 12 hours, but your liver is significantly going to be damaged. And a lot of times they put these patients on dialysis quickly to try to pull some of that off. So there's acetaminophen, and we'll move on to our next one. All right, the next drug, very similar to acetaminophen, is going to be ibuprofen. And much like your acetaminophen, there's quite a list of trade names. The ones that we're most familiar with are Advil and Motrin and drugs of that sort. Under class, we're going to call ibuprofen a non-steroidal anti-inflammatory drug, so it is an NSAID. We're also going to put a identification marker on it, much like we did the acetaminophen. If you remember the acetaminophen, we primarily called it a COX inhibitor. Well, this one is very similar to that, and we're going to call it a prostaglandin antagonist. Remember that the word agonist means that it stimulates a certain receptor, and antagonist means that it blocks or interferes with a certain receptor. And so we're going to say that this here is a non-steroidal anti-inflammatory drug, and more specifically, it is a prostaglandin antagonist. Now, how it works is, of course, we know that ibuprofen is an analgesic. It is a painkiller. It also is an antipyretic, so it also helps with fever reduction. And it does this by blocking the synthesis of prostaglandins. Now, how it does this is by interfering with an enzyme called cyclooxygenase, which we've already talked about. Well, cyclooxygenase, which is your COX inhibitor, actually catalyzes the conversion of arachidonic acid into prostaglandin. So that's quite a mouthful, in fact. But basically what's going on there is that the ibuprofen is blocking the synthesis of those prostaglandins. Remember, prostaglandins are the primary enzyme catalyst that stimulates pain receptors, and so that's how it blocks pains. Under indications, we're going to give this to patients to help reduce their fever. We're going to give it for mild pain such as headaches and muscle aches and things of that sort. Menstrual periods, toothaches, just minor pain issues, and it's also a good alternative for our antipyretic fever reduction. The dose of it in your adult is between 200 to 400 milligrams every 4 to 6 hours. In pediatrics, between 6 to 12 years of age, usually we give them somewhere between 5 to 10 milligrams per key every 6 to 8 hours. Only major contraindication to it, besides being allergic to it, of course, is we try to avoid giving any of these NSAIDs to anyone who has a bleeding disorder, such as hemophilia or a bleeding ulcer or anything like that. Because many of those COX receptors and many of those prostaglandins also are part of the clotting cascade. So giving anything that interferes with that actually interrupts some of the clotting factors in your body. Only thing really to remember under special considerations on ibuprofen is remember that NSAIDs irritate the gut, and as I said, they reduce blood clotting, which makes bleeding more likely in these patients that may have trauma or something of that sort. It is a pregnancy category C, and if they overdose on ibuprofen, much like your acetaminophen, the only treatment is if you can get to them within 30 minutes of the ingestion, we give them activated charcoal to try to absorb it. After that 30-minute mark, when it is actually already absorbed into the stomach and been broken down, the only thing that you can do for them is put them on dialysis. It is quite important that they get put on dialysis because much like the Tylenol, ibuprofen overdoses will damage and potentially shut down your liver. And so a lot of times they'll put them on dialysis to try to filter some of that out. All right, let's turn our attention back to another NSAID and another COX inhibitor, but it's a little different type. We've been talking about those that patients take PO a lot. Well, this one can be taken PO too if you're given a prescription for it, but we use this one quite a bit in both the pre-hospital and the emergency room setting to manage pain in which you do not want to give the patient an opiate. And so the next drug is going to be ketorolac, which we typically call by its trade name Toradol. Okay. As you can see here on the slide, Toradol is an NSAID, so you can classify it along with your ibuprofen and along with your acetaminophen. And much like your acetaminophen, it is also a COX inhibitor, so you can write it as a cyclooxygenase inhibitor. And that's how it works. It's an anti-inflammatory drug, and we believe that it works by blocking both cyclooxygenase 1 and cyclooxygenase 2 inhibitors. Now, if you'll go back and remember, we talked about Tylenol a while ago. We talked about acetaminophen. That acetaminophen is primarily a COX-2 inhibitor, where Toradol is thought to affect both your cyclooxygenase 1 and your cyclooxygenase 2. That's the reason why Toradol is a little bit more powerful and a little bit more beneficial to patients with certain specific types of pain. What happens is because you are blocking prostaglandin synthesis, that leads to decreased formation of all of those precursors, of prostaglandin, all those precursors to thromboxane, arachidonic acid. All of those things being inhibited, of course, is partially responsible for the therapeutic pain relief. The analgesia is probably also produced via peripheral action, in which basically it blocks pain impulses by decreasing all that prostaglandin activity in the peripheral system. You'll notice here it says, however, inhibition of the synthesis or of these substances that synthesize pain receptors may also cause some of the analgesic effect to it. We give this for patients who are in moderate to severe pain. You're going to use this primarily for patients who have either pulled back muscles and have a muscle spasm, or the more common use for Toradol is going to be kidney stones. One thing that this drug does is, because of its anti-inflammatory properties, it causes smooth muscle relaxation of the urethras. That really helps a lot with your kidney stones because it allows the urethras to relax, and that not only helps with the pain but also allows the kidney stone to pass through the system. So you see us giving this quite a bit in the ER for your kidney stones. But we combine it almost every time with morphine or with fentanyl. We combine it with some type of opiate to help with the actual pain itself, because this drug does not eliminate all the pain, it just decreases the synthesis of those pain enzymes. So the dose of Toradol here is 15 to 30 milligrams. We give 30 to 60 IM in the hospital quite a bit. In the ER, when we've got an IV established, we typically give them 30 milligrams of Toradol. If we're going to give it to you IM, we give you usually 60. We don't use Toradol in peds. If they're allergic to aspirin or if they have asthma, we do not give them Toradol because of the antihistamine responses when you take out some of those prostaglandins. That can lead to an increase in asthma reaction there. It does sometimes cause GI irritation or hemorrhaging. That's usually only if you take it PO. It has a pregnancy category of C, and there is no antidote for overdosing on it. To be honest, I cannot say that I've ever known anyone to overdose on Toradol. You can get this when you pull a muscle in your back. A lot of times you get this prescribed to you in a PO form. But I can tell you from experience, Toradol really doesn't do enough in its anti-inflammatory properties to make it an abusive drug. It's a category, I think it's a Schedule 3 or a Schedule 4. I need to look, but I believe it's a Schedule 3 drug, or maybe even be a Schedule 4 drug there with Phenergan. Not very addictive, doesn't have a high abuse potential. So very seldom do you see anyone overdose on Toradol. Alright, the next drug is one we're very familiar with, acetylsalicylic acid. Except no one out there calls it acetylsalicylic acid. We always call it by its trade name, which is simply aspirin. It goes by a lot of names: Bayer, Bufferin, Ectrin, Halfrin, St. Joseph's, Aspartab. There's a long list of names that classifies trade names, but the generic name for it is acetylsalicylic acid. All right. Now, we're very familiar with this drug, but it has multiple usages and multiple classifications. And I've listed here just a couple of them. It is a salicylate, it is an antipyretic, and it also can be classified as an NSAID. But this drug is also primarily, and on your drug cards, you would want to write this drug is also an antiplatelet. It's an antiplatelet, it's an antipyretic. It's a non-opiate analgesic, and then an NSAID, an antipyretic, and a salicylate. You know, a lot of how aspirin works we're still learning, but one of the key facts about it is its anticoagulant and its antiplatelet mechanism. We know that the antiplatelet activity is produced by decreasing the synthesis of certain substances that mediate platelet aggregation. It also causes a synthesis of substances that cause many of the arteries to constrict. And so we've learned a lot more about it. What we are pretty confident that it does is it inhibits thromboxane A2 production. Now, thromboxane A2 is one of the significant clotting enzymes that leads to many of those factors that are playing a part in blood clotting. Its major actions seem to be associated with inhibiting the formation of prostaglandins, which is where it gets its analgesic effects. It also is involved in the blocking and causing a decrease in inflammation, a decrease in pain, a decrease in fever. All of those things are associated with the prostaglandin inhibiting that's occurring. We also know that aspirin lowers body temperature indirectly by basically causing centrally mediated peripheral vasodilation. If you've never seen someone that's overdosed on aspirin, they will be flushed, they'll actually be sweating, and it's because of those peripheral enzymes that are being released there. So this is a thromboxane A2 production inhibitor, which would be another important thing to know for your test. We give this drug for acute myocardial infarctions. We give it to relieve pains of low to moderate intensity. We give it occasionally for some inflammatory conditions such as rheumatoid arthritis, things of that sort. We also occasionally use it to reduce fever. The primary place that you will utilize it as a paramedic, of course, is going to be for your acute myocardial infarctions. I would like to tell you that a lot of the research that's being done, including some of the research that I've done, shows that there's not a significant correlation with aspirin preventing long-term damage from an acute MI, which means if you have an MI today and you're given aspirin today, the research really is not too conclusive that that's going to make any massive difference. Now, the research does show that if you're on an aspirin regimen every day, that you have a decreased likelihood to suffer long-term incidents from your infarction. So I think over the next few years you'll see some interesting changes in the whole aspirin regimen. The dose of aspirin, 325 milligrams PO. It's applied in 81 milligram chewable tablets. You give 4 of those, which equals 324 milligrams, which is as close as you can get. The dose in all of your textbooks say 325 milligrams, yet it is impossible to give a 325 milligram aspirin when you give 81 milligram tablets. So you get close as you can. You may be wondering, well, what am I going to put on the test? If 325 is on the test, that's the answer. If 324 is on the test, I'd go with that one too. Depending on which protocol you look at, depends on exactly which one they use, but they're the same thing. Contraindications for this drug. If, of course, they're allergic to salicylates, we don't want to give it to them. Because of its anti-clotting, its anti-platelet effects, we do not give it for patients who have a history of GI bleeds or GI ulcers. We do not give it to patients who are hemophiliac or have any other type of bleeding disorders. Aspirin is considered to be a pregnancy category D drug in pregnancies. So we avoid giving aspirin to pregnancies unless absolutely necessary because it weakens the placental barrier and the capillary beds there at the placenta. And we also do not use aspirin for children under the age of 2. There is an antidote for aspirin overdoses, which I do not have up, and that is a concoction called Mucinex. If you ever smell it, you would think that it was rotten eggs, because that's what it smells like. And that is the antidote you use for it. Now, if you overdose on aspirin, it is really detrimental to your liver, much like Tylenol. And so, now on the bright side, the peak level for a true overdose is quite high. But if you get these kids who are they don't pay attention, and if you've ever thought about it, baby aspirin tastes like oranges, so that kids will eat it. Well, if you have a couple of bottles of baby aspirin in your cabinet and your children get into those, or if you have several bottles of the liquid and your children get into those, they're quite tasty, quite yummy, and so it is possible you would suffer some type of overdose on a aspirin, and so that is something to be concerned about. Some of the other things that it can cause, if you give large amounts of aspirin, it may cause tinnitus in the ears. They may start complaining of ringing of the ears. That's just due to once again, the change in thromboxane that occurs. All right, let's move on to a couple of other drugs that are associated with the opiates that we mentioned earlier. And the first one we're going to talk about is naloxone, which is going to be your opioid antagonist. Naloxone's trade name is Narcan, It is an opiate antagonist. It is a competitive opiate antagonist. So I'd like for you to make sure you write it is a competitive opiate antagonist. Now, what it means when we say that it's a competitive antagonist, that means that it could be knocked off with the right force. We'll talk a little bit about that in class. It is a competitive narcotic antagonist. We use that as an antidote to reverse overdoses on opiates or narcotics. We can even use it for synthetic narcotic agents. When you compare it with some of the other narcotic antagonists that we'll look at, here's the key to it. The other ones do not completely inhibit the analgesic properties of opiates. Naloxone antagonizes all the actions of morphine, and so it will completely reverse your opiate, and it completely blocks it. But here's what the issue is about it being competitive. If I was to overdose on morphine and I was to be given Narcan, the Narcan will knock the morphine off. But if I was to take enough opiate, that opiate could eventually retake over the receptor. So it does not work like the drug we'll look at in a minute called Romazicon. The naloxone is competitive, so it has to compete for that site. But when it does attach to the receptor, it completely blocks it. So there is no partial blockage, and that'll be important. You'll see a drug in just a minute that is a partial blockage. And so naloxone is our opiate reversal overdose. We have to be very careful about giving this. Many times if we push this drug on a patient who has got a long history of opiate overdoses, they will seize on us, and so we got to be real careful about when and who to use that on. When we look at the dosages of this drug, the adult dosage is 0.4 to 2 milligrams. Now, if you want to know where to start, we typically tell you to start around 1 milligram of Narcan and then start to reverse it off. Your PEDS dose for it, in case of PED overdoses on an opiate, is 0.1 milligram per key. So that's 100 mics. 0.1 milligrams is 100 mics per key. And we definitely need to learn that one. That is one of those you have to learn. By the time you finish pediatrics in a few semesters, you have to know that the Narcan dose for pediatrics is 100 mics per key or 0.1 per key. So go on and lock that one in your pediatric memory. As I mentioned earlier, there's no contraindications for it necessarily, especially in a life threat. But we have to be very considerate that if we give this to a patient who is dependent on opiates and has a narcotic problem, this drug could cause them to seize as they come off of it. There's a lot of drugs such as Darvon, which requires much higher doses of Narcan for reversal than we carry. So if they've overdosed on something like Darvon, you're not going to have enough Narcan in your ambulance. You're going to need something a lot more powerful and a lot more in dosage. But be very careful about seizures. We'll talk about in class when do we choose to reverse the opiate overdose versus when do we choose to manage their airway, intubate them, and let it wear off. And it's a simple rule. If you can stabilize the patient and manage the patient, if you can keep their airway protected, if you can intubate them, if you can manage their blood pressure and their heart rate, most of the time it's better to let your opiates wear off. But if you're in a situation in which the patient is literally crashing, is becoming unstable, then Narcan is the drug we can go to. All right, this drug is a little bit out of order, but keep in mind that when I was making the list, I was making the list based off the drugs that we had or the medications we've been using. But this one's a little bit out of order, but let's go on and look at it. The generic name for this drug is called Nalbuphine. But it goes by the trade name that most of us are familiar with called Nubain. It is a wonder drug. It is a synthetic opiate agonist antagonist. Now, if you've got your flashcards out, you want to put a big, huge star out beside the fact that this is a agonist antagonist. There are not many drugs that would be classified as agonist antagonists. So you want to make sure you make a big note of this. Now, what that means, it means that this drug has both the good parts of the opiate that we want for pain relief and it has none of the negatives, or not many of the negatives that we would like. And so, pretty good drug. So let's take a look here. It goes by the trade name of NuBane. It's a synthetic opiate agonist-antagonist. What this drug does is it produces analgesia by binding to the opioid receptors such as the mu and the kappa. But it also produces a partial antagonist effect by inhibiting certain opioid receptors in the central nervous system, primarily those that are located in the medulla, specifically the vasomotor center and the respiratory center. And so here's what all that means. This drug is going to cause all the stuff we like. It's going to bind to the mu receptors and the kappa receptors, causing the analgesia, causing the pain, causing the euphoria. But it is not going to cause the problems from the medulla, such as vasodilation, such as respiratory depression. And so what this drug basically does is it allows us to give this without causing some of the nasty respiratory problems and many of the vasomotor problems. Sometimes this is preferred in chest pain because it does reduce the oxygen demand of the heart without actually changing the blood pressure. But I've got to be honest, I don't see it given a lot for chest pain protocols. But it would be a good idea sometimes. We give this primarily for moderate or severe pain. The dose of it is 10 milligrams for the adult. We can give it IV, we can give it IO, IM, or sub-Q. So there's a lot of routes we can give NuBane. It's not recommended in peds, and you do not give it to anyone who has head trauma or anyone who has undiagnosed abdominal pain. But you're going to find this drug being one we use quite a bit. Some of the things you got to watch out for is it can cause asthma or COPD to worsen. If you're taking this with antihistamines such as Benadryl, or if you're taking it with antidepressant medicines or any other sedative hypnotic type drugs, it potentiates it. So I got to tell you, you see a lot of hospitals putting NuBane in with their Versed, because you can put a tiny amount of NuBane in and add a benzodiazepine such as Versed, and it is a potentiation effect. And so NuBane's a pretty good drug. It has a category B drug when it comes to pregnancy, which means it's very safe for pregnancies, and it's actually used quite a bit in pregnancies. And like all of your opiates, it's reversed with Narcan. So this is one you're going to see in the hospital used quite a bit. And I've got to tell you, if you were going to give me an opiate, I think NuBane's the way to go. It's a great drug, but it also is a Schedule II drug. It is extremely habit forming, and you can develop a dependency on it very quickly because of its effects. The next one we have is another one of our synthetically made opiate agonist-antagonist. So this one's very similar to NuBane. It is called butorphanol. Have to say it right. Butorphanol. Nobody calls it that. Everybody calls this Stadol. It is also made synthetically in a lab. It is also an agonist-antagonist. It is an analgesic of the phenanthrene series. Remember that one? That was the one that dealt with the kappa receptors. And I want you to look at the schedule of it. This is what's very interesting, is that Stadol is a Schedule IV opiate. There are very few narcotics that are Schedule IVs. Its agonist-antagonist properties are very similar to that of NuBane in that it binds to certain receptors, primarily your kappa receptors, and it does not bind to many of the other ones that are associated with vasodilation and things of that sort. We give it for patients who are in moderate to severe pain. You also give this medication quite a bit as a pre-op or a pre-anesthetic medication, because it does cause you to kind of have a euphoria. You kind of lose the perception of pain and what's going on. They use it as a supplement to help balance anesthesia a lot, and they occasionally give Stadol for pain during labor because it's very safe for your pregnancies. and it won't change their blood pressure status. The dose of it for your adults is 0.5 to 2 milligrams. Only ones we really are worried about is those with pulmonary problems, those that have liver disorders, and if they're taking alcohol, this drug will cause significant potentiation. So be very careful about that. Notice that it has the potency of about 5 times that of morphine. And so this drug is quite significant. That's why you see it labeled as a Schedule 4 a lot of times. It has a pregnancy category C. Some of your books say it's a pregnancy category B, and it's pretty safe for pregnancies. And the antidote for it, like all of our opiates, is going to be Narcan. Alright. Next drug on our list is going to be a totally different class. Now, I wish I could tell you that we're done with all the opiates, but I haven't looked yet. Let's see. Actually, I am done with all the opiates, so I did put them all up front, which is a good thing. Now we're going to turn our attention towards some anesthetic medicines, and more importantly, we're going to turn our attention, first of all, towards our benzodiazepines. And so this is the first one we'll deal with. Now, both opiates and narcotics, such as morphine, and your benzodiazepines, both of them have the same outward physiological effect. Both of them cause the patients to get drowsy, have euphoria, have a decrease in pain sensation. Both of them do some of the same outward appearances. But what I want you to understand, and we will talk about this in class, is that they both work in a totally separate spot. Where all of your narcotics are working on opioid receptors located through the body. Remember the mu, the sigma, the kappa, the delta, all of those different receptors. Benzodiazepines work by affecting GABA. Okay, and we'll talk about GABA a little bit in class, and I'm sure you've read about it. But I want you to think as GABA is the feel-good of the body. GABA stimulation and the release of GABA is what causes euphoria. It's the feel-good enzyme of the body. So let's look at our first benzodiazepine. The first one we're going to deal with is diazepam. Now these get a little confusing because there's a lot of ams and pams and zams in it. So you're going to have to make sure you keep them separated. And the first one is diazepam, which of course is our familiar famous Valium. I want you to write as a class on it that is a benzodiazepine. It is also a sedative hypnotic. It is also an anticonvulsant. It's also a skeletal muscle relaxant. So I need you to know all of those different classes for your benzodiazepines. Now, here's the question that deals with our benzodiazepine discussion. What is the difference between an analgesic, which if you'll notice this is not, and a sedative hypnotic? Well, the difference is very simple. A analgesic is a medication that interferes with the body's pain sensation. It stops either the receptors at the site of the injury from being stimulated, or it stops the brain from being able to detect those pain sensations. And it can do that by blocking the receptors. It can do that by inhibiting prostaglandins, which are our pain stimulators. But basically, analgesia means that it stops the body's ability to perceive pain. If you give me morphine for my broke leg, I may not perceive necessarily the pain coming from that leg, but I know it hurts. Now you say, well, BG, that's the stupidest thing I've ever heard. Well, the fact is, my brain has both a conscious and a subconscious part, and we still do not understand how all of that works in sensation. But I can tell you that a person with a broke leg, even if you give them morphine, as long as they're still conscious, they still are hurting, at least in their mind. Their body may not be able to truly sense the pain, but because they can see it, their brain interprets that in the subconscious as pain, and so they're going to have those pain symptoms. A sedative hypnotic drug actually stops the brain's ability to perceive what's going on. And the hypnotic part, remember that hypnosis is dealing with memory and amnesia. And so basically what it means is a sedative hypnotic, when you give that to me, that makes me calm down. I kind of lose perception on the events that are going on. And on the hypnotic side, I actually forget the events happen. So which one do patients in pain need? Do you want to stop the pain, or do you want to stop them from remembering the pain? Well, of course, the answer is both. This is why anytime you give a patient pain medicine, if you have the ability to in your protocols, if it's a significant pain problem, then giving them a little bit of a sedative hypnotic helps. Now, if I hurt my back, I can't see my back pain. And so analgesia would probably be all I need there. If I'm having chest pain, I can't see my chest pain. And so analgesia would be a great treatment there. But if I have a significant musculoskeletal injury, if I have some type of gross deformity, or if I'm having pain associated with some type of anxiety issue, then you know what? Giving me a little sedative will not only calm me down, it will help me lose perception of the events. And when the event is over with, I may remember looking down and seeing a broke leg, but I will not remember the events or the pain sensation that was associated with that. So we're big supporters here at Jones about you giving not only a little bit of pain medicine, but you also give a little bit of sedative hypnosis out of your benzodiazepines. Now, all of that being said, this drug is not really the best drug of choice for that. We use this drug primarily for its anticonvulsant properties. It is a benzodiazepine, which means it works by potentiating the effects of the inhibitory neurotransmitters of GABA. What that means is that it hyperpolarizes the membrane potential and it raises the seizure threshold in the motor cortex. Think of it as raising the bar that your seizure has to make it to before your body actually has a seizure response. And so it raises the seizure threshold. We use this to treat seizures. We use this to treat DTs from alcohol, drugs, and withdrawal. We use it to treat grand mal seizures. You can also use it to consciously sedate patients that you're going to cardiovert or defibrillate or pace, because it actually it causes amnesia. You know, if you're going to pace somebody, please give them some sedation, okay? Because you don't want them sitting there remembering what it's like to have electricity going through their chest wall. You say, well, why don't I just give them some analgesic for that? Because when you see someone hook a machine up to you and it literally makes your muscle spasm, you know it's supposed to hurt. And so giving them a little bit of a sedative actually does away with that subconscious or that visually associated pain symptom. So, and Valium's good for that. You can give Valium before you pace or you cardiovert somebody. Valium is something that's going away. Valium is the old drug of EMS. It's the old drug of seizures. It's the old benzodiazepine. And I'm thinking you're going to see a significant change. Almost every system has already started placing better benzodiazepine, better sedative hypnotics on their drug. But we still need to know Valium because it's important. It is a good seizure medication. And so the dose of Valium, as you see here, on the adult is between 5 to 10 milligrams. Now, we can go all the way up to 30 if we need to. But 30 milligrams of Valium is a significant amount of Valium. And so, but the max dose is 30. General rule, you have a patient who is suffering a grand mal seizure, we typically give them 5 milligrams. If they do not respond to that, we give them another 5, and typically we use increments of 5. For sedation, for cardioversion, usually between 2 to 5 is significant enough. Make sure you give this drug slowly. Make sure that you push it slowly. Do not slam Valium on someone. Be very careful. It is contraindicated in patients who have acute glaucoma because Valium causes an increase of intracranial pressure. And intracranial pressure is directly related to intraocular pressure, which is what acute glaucoma is. So if the patient has glaucoma and you know that, we try to stay away from Valium because it will spike their intraocular pressure, therefore spiking their intracranial pressure. We also obviously don't give it to patients who have CNS depression, and we also don't give it to patients who are already hypotensive. Valium is going to cause a depression of the medulla, which means you're going to have vasodilation. You're going to have a decreased respiratory. Remember, the cardiovascular center, the respiratory center, and the vasomotor center in the medulla all get affected by this. And so you're going to see a decrease in heart rate, a decrease in respirations, a decrease in blood pressure. So be very careful about giving that to a patient that's hypotensive. If you accidentally push Valium through an IV that has necrosed, you will cause significant tissue necrosis. Give this very slowly, okay? Because it is only soluble in propylene glycol, which, by the way, your body doesn't have any. And so when you push this into the tissue, not into the blood vessel, it causes significant tissue necrosis. So be very, very careful with that. This drug is not used for pregnancies. It has a pregnancy class of D. Now, if the patient is having a grand mal seizure and is pregnant, and you have no other benzodiazepine drugs to give them, then you could still administer Valium. But it is only as a last resort because of its danger to the fetus. It actually will go through the placenta membrane, and so you give a mother Valium and it will affect the child. So you've got to be real careful about giving that. The drug that you use to treat an overdose of diazepam is a drug called Romazicon, which we'll look at in just a few minutes, and we'll talk about the significant dangers of giving Romazicon also. So this drug acts both at the limbic system, it acts at the thalamic system, it acts at the hypothalamic system, and it deals with all type of skeletal muscle relaxation and anti-convulsion. And so this is a drug that has had quite a large repertoire over the years. So remember that it is very thick, and that's because it is not soluble in water. And so anytime you go to give this medication, you can give Valium IM, but you've got to push it really slowly, and you need to make sure that you give this very deep IM. So it has to be deep. No faster than 5 milligrams a minute. So you got to be real slow on this. So. Alright, so you've learned diazepam. Now it's time to learn lorazepam. Diazepam is Valium. Lorazepam is Ativan, which is another one of our benzodiazepines. You'll notice here that it's got some of the same classes. It's an anti-anxiety, it's a hypnotic, it's a sedative. Ativan actually has an antiemetic property also. It's an anticonvulsant, and it is a GABA modulator. Does the same type of stuff that your Valium did. It binds to the allosteric sites on the GABA A receptors. By the way, there are lots of types of GABA receptors, just like there were many types of opiate receptors. This is the pentameric inotropic receptor in the central nervous system. When it binds to this site, it potentiates the effect of the inhibitory neurotransmitter GABA. When it does that, it opens the chloride channels in the receptor, allowing chloride to flow in. That causes a hyperpolarization of the neuron cell membrane, which results in a state of sedation, hypnosis, skeletal muscle relaxation. This is a really beautiful mechanism of action for all of your benzodiazepines. And so I wrote this definition several years ago, and so you may want to, or used part of it, copied part of it. This is a really good illustration on what these benzodiazepines are doing. Is because when chloride flows in through the opening of the chloride channels, you get a hyperpolarized state of the neuron. That means that neuron cannot respond correctly, which is what causes your sedation and your euphoria feelings. We use Ativan to treat anxiety, to treat seizures. We use it for induction or for amnesia, for events and for procedures that are performed a lot of times. We use Ativan quite a bit for anxiety. It's a good drug to give to just calm someone down that is having anxiety attacks and things of that sort. I'm looking to see here. The dose of lorazepam is 2 to 8 milligrams. 2 to 8 milligrams. Just to make a note, the literal dose from a medical perspective is 0.44 milligrams per key. That is the weight-based drug that most of your hospitals and things go through, is 0.44 milligrams per key. It's a Schedule 4 drug, so you don't have a whole lot of potential for abuse there. Just like the others, be careful about giving it to glaucoma, depressed individuals, shock, etc. You do not dilute the IM dose. Everything else you dilute, you have to dilute with saline. Make sure you are prepared, watching that blood pressure. If you were to accidentally give this through an A line or an arterial line, it can cause an arteriospasm, which we will talk about later, which can cause you to lose tissue and can cause gangrene. So let's not put it in an artery by accident. And then one of the big things you'll notice here right at the end is it expires in 4 weeks when not refrigerated, which is why it is not on the ambulance as often. It's because you have to have it cooled, and that's a big issue. Has a pregnancy category D. And the antidote for it is, of course, bromazepam. Alright, the last LAM that you've got to learn, we've learned diazepam and lorazepam, and now we're going to learn midazolam. Midazolam is also known as Versed. It is a short-acting benzodiazepine. It is a sedative hypnotic. We use it as an anti-anxiety agent. It is a GABA modulator, and it also has a bit of an anesthetic property to it. Like the other benzodiazepines, this benzodiazepine increases the activity of GABA. Therefore, it produces a calming effect, a euphoria. It relaxes skeletal muscles. It does induce sleep, which is part of the hypnosis effect. They bind to the benzodiazepine sites on the GABA-A receptors, which potentiates the whole effect of GABA, making it more powerful. That also increases the frequency of the chloride channels that open, and as we said, that hyperpolarizes the neuron. We use it to help sedate patients. We use it for anxiety. We use it for seizures, and we also use it for medicated assisted intubation. When you give enough Versed, they go down to a point they lose a gag reflex, and you're able to intubate them. Drug dosaging for it, there's a large range, but for our adults, we usually give between 2 to 5 milligrams of Versed. We usually try to do that in 2 milligram increments unless you go all the way up to the 5 milligram level. The dose for PEEVs is 0.1 milligrams per key. That's another 100 mics per key that we mentioned earlier. That 100 mics per key is very important when we talk about assisting kids to be intubated. We do not give it to patients who have acute glaucoma or who are pregnant or who have some type of increased interocular pressure. Of course, the side effects are like all the other ones: confusion, impaired coordination, diminished reflexes. Versed a really good drug. Versed doesn't cause the vasodilation and the drop of blood pressure that many of your other benzodiazepines do. And so it's a really good drug when it comes as far as keeping their hemodynamic status. It does have a category D pregnancy level, and the antidote for it is your bromazepam. So there you go. You've got your 3 major benzodiazepines that we've mentioned: lorazepam, diazepam, and midazolam. And so all 3 of those are very important. Make sure you learn each one's name and dosage. So we've learned our opiates, our narcotics, and then we've spent some time learning our benzodiazepines, which are primarily sedative, hypnotic type drugs. The next drug on our list is a great example on how you never know how drugs will find their way into the EMS and the healthcare setting. We've taught this drug for several years, but it has always been taught kind of with the prefix to it that this is a drug that is something we need to know about because of its categorization, but it's a drug that we would never use. Well, things have changed, and this drug has found its way into EMS, and it's found its way into the ERs and onto the helicopter and critical care settings. It's done that primarily because of the shortage of a lot of the drugs that we've been trying to gather. And so it's kind of interesting that we're now teaching this drug when it comes to EMS. And that drug is ketamine. Ketamine is a drug that if you look it up in the old pharmacology book, you'll have to find it under street drugs. It goes by large amounts of name. It's actually ketamine hydrochloride is actually the full generic drug name. It goes by Ketalar in our hospital type settings, but it has a lot of street names. Special K, Super Acid, Vitamin K, Jet, Cat Valium, Purple, Bump, Keats. There's a large list of names that go along with ketamine. It is a non-barbiturate anesthetic. It also is a non-competitive NMDA receptor antagonist. It is got a sedative classification. It also is a hypnotic, and the last part is it is a hallucinogenic. This drug produces a state of anesthesia while maintaining airway reflexes, heart rate, blood pressure. It is a class of anesthetic that works to antagonize or inhibit the action of the sodium methyl deasparate receptors located within your bodies. We typically give it for pain. We also give it for anesthesia for short procedures. This drug learned in the market because it is known as one of the date rape drugs, because it was a drug that could be given or could be taken voluntarily, and it would cause euphoria, hallucinations. It would also cause amnesia. It was used as a date rape drug quite a bit because it could be given to patients and or individuals, and they would be able to take advantage of them, and then when the event was over with, they couldn't remember the event. And so that's why it used to be a pretty high street name. The dose of it is 1 to 4.5 milligrams per key. If you give it IM, you go up to 6 to 12. If you give this drug at 4 milligrams per key, you're in the right range for it. Pediatrics is 0.5 to 2 milligrams. The only concern you have to worry about is if you give this to a patient who has glaucoma or heart failure or hypertensive problems, it sometimes can cause significant problems with that. So be very careful about giving it to someone who already has a high blood pressure concern. You know, patients who are having heart attacks or head injuries or things like that, that the spike in the pressure may cause a problem. You give it over 60 seconds. Usually within 30 seconds you have the response you wanted, and it can last usually up to 5 minutes. We use it also a good bit because it helps with psych patients and calms them down. It has a pregnancy category of C. You're finding it on the helicopters right now, which is kind of interesting because of drug shortages. I would tell you that this is a drug that we won't ever see on the ambulance again, but you never know the way things are. Nitrous oxide is another medication. It's known as Nitronox. It is an inorganic gas. It's also a gaseous anesthetic. It's the only one. So on test, I kind of figure you'd need to know that it is the gaseous anesthetic, the inorganic gas. It's a mixture of 50% nitrous oxide and 50% oxygen, and when you inhale it, the nitrogen oxide and the oxygen depresses the central nervous system, which causes your anesthesia. In addition, the high concentration of oxygen delivered with the nitrogen oxide increases the pressure, the partial pressure in the bloodstream, which is your oxygen tension, and therefore it reduces hypoxia. This is the medication you're given in your dentist offices and places such as there. It's a really great medication to manage severe pain and to manage anxiety and apprehension. It was on the ambulance at one time, and in Europe they use this quite a bit to manage patients who are anxiety or in significant amounts of pain. It has a lot of great effects. One, it's quick. One, it's easy to discontinue. One, it's easy to administer to patients, so you can give them this to calm them down while procedures are done. The problem is one problem is it gets abused in the pre-hospital setting quite a bit. And another problem is, as you will learn in diving and drowning emergencies, if you're not careful and you do not mix the nitrous oxide correctly, you can cause too much nitrogen gas inside the bloodstream, which can interfere with the partial pressure needed inside the bloodstream. It can actually cause nitrogen narcosis if you're not careful. The dose of it is about 20 to 50% oxygen combined with the nitrous oxide. We don't give it to head injuries, chest trauma, decompression sickness, abdominal pain that's undiagnosed, hypotension, bowel obstruction, or COPD. One reason why we took it off trucks also is because there's so many people that can't have it, it made it a liability. Notice here in the special considerations that nitrous oxide is 34 times more soluble than nitrogen. It will diffuse into pockets of trapped gas, which is part of that nitrogen narcosis. And as the nitrogen leaves, it is replaced by larger amounts of nitrogen oxide, which causes a pressure problem. By the way, nitrous oxide is a non-explosive gas, just to let you know. And we know that nitrogen oxide has been shown to increase the incidence of spontaneous abortions. That's why we do not use it in pregnancies. There's no antidote for it. The antidote would be to take it off of their face and to give them plenty of oxygen. All right, our next drug is known as propofol. Now, I'm thinking that this medication will never be on the ambulance, but we never know, as we've already said. Propofol has a trade name of Diprivan. It is a sedative hypnotic anesthetic. It binds to the GABA receptors in the central nervous system, and once bound there, that reduces anxiety, induces sleep. Propofol is known to bind to these sites in sufficient quantities to induce a dreamless, near coma-like sleep. This medication is used primarily as an anesthesia induction. They use this in surgery. They use this as a medication for conscious sedation. It is also known as milk of amnesia because of its white appearance. This drug is pretty amazing. You start this drug on a patient and you turn it on and set the rate. And usually before the patient can count down from 20, they're unconscious in a dreamless coma. But their blood pressure, their heart rate, all of those systems stay intact. When you cut it off, within a minute, they are back awake. This is the drug that Michael Jackson found himself overdosing on. And this is a drug that's also lipid-based. It is a lipid-based drug, which means primarily that bacteria loves it because of the lipid appetite they have, in a sense. And so this drug really needs to be used on a sterile type environment with sterile procedures because there's a high risk of developing infections because of the high lipid concentration of this drug. But it is a great drug when it comes to needing to put a patient under to intubate them. You'll see this drug used quite a bit in surgery. The dose is 25 to 75 mics per key per minute. The pediatric dose is around 125 to 300 mics per key per minute. You may say, why is it necessary to have more for the ped than it is the adult? That's pretty common in a lot of your sedation or paralytic drugs. So we don't give it to patients who are hypovolemic because it's made out of a concentrated lipid solution, which is, by the way, why it works so quickly. It works quickly because the lipid-soluble medication can go across the membrane of the central nervous system almost instantly because of the design of the cell membrane, as we've talked about. Remember, water-soluble has that hydrophilic membrane and hydrophobic membrane that pushes water away. But we don't give this to a patient who's allergic to soybeans, if he's allergic to oil or eggs, because of the lipid concentration in the solution. Very rapid induction. Make sure you put it in a big vein because it can necrose the vein pretty easily. It is a category B because it does not cross the placenta barrier, and that makes it an extremely good drug to use when you're needing to do procedures such as C-sections and things of that sort. It has a short half-life, and it is gone in about a minute, which means there's not really a need for antidote. You just cut it off. Here is another very important drug, etomidate. Etomidate is the one that you're going to want to make sure you remember, and its trade name is Amidate.